আজকে ওয়াদুদ নেই।
Assalamu alaikum and good evening, respected physicians. Welcome you all in today's webinar on ECG Basic and Beyond, organized by ECG Study Group. Today, we have 35th lecture on ECG in clinical practice. And our today's speaker is Professor Khaled Mohsin, sir. We have two parts in this lecture session. The first part, Dr. Khaled Mohsin, Professor Khaled Mohsin, sir, will give a lecture on ECG in clinical practice, and the second part, Professor Dr. Chowdhury Hafiz Ahsan, Dr. Christoph Sisu, and Dr. Omar from USA will provide lectures. So before starting the session, I request Professor M. Atahar sir to introduce Professor Khaled Mohsin, sir, to us. Atahar sir.
Sir, unmute yourself.
Atahar sir, please unmute.
Hello, thank you, Dr. Tushar. Very good evening to all the participants from the panelists and participants from the Bangladesh, and good morning to all the panelists from USA. Particularly, I am very much glad to welcome Dr. Christoph Sisu and Dr. Omar from USA as a panelist in our today's session. Sir, today's speaker is Dr. Khaled Mohsin. Khaled Mohsin does not need any introduction in Bangladeshi, actually, the Bangladeshi participants. Dr. Khaled Mohsin is a great teacher, always loved to teach. He is very much academic, methodical, leading interventional cardiologist. He is actually my teacher, and I think he is teacher of many of our established cardiologists right now. He is Dr. Khaled Mohsin. He has recently joined as a professor of cardiology in Universal Medical College. And as per suggestion of our Dr. Rafiq Ahmed sir, we have introduced our as a special category, that is some medical colleges and their cardiology department will lead this session. So today, this is the first session as a medical college. Professor Khaled Mohsin will represent Universal Medical College as a today's session. And Professor Khondokar Kamrul Islam will be with him, Professor Khaled Mohsin. And Universal Medical College, sir, this is a new medical college, one of the leading new medical colleges in Dhaka. And it is a private medical college, and it is one of the leading medical colleges. This medical college has got the established cardiology department, and Professor Khaled Mohsin is leading that department. And finally, I also like to welcome our Rafiq Ahmed sir, international faculties from the USA, and Dr. Chowdhury, Hafizul Hassan, and many of our faculties in today's session, Professor Mohsin Hussain, Professor Chandan Kumar Shaha, Professor Rohit Sundir Mandal from Rajshahi, and Khondokar Asaduzzaman from Asghar Ali Hospital, A.M. Shofiq from United Hospital, and Abdul Jamil from the Asghar Ali Hospital. So this is very much good evening, and it is a nice evening, I think, sir. This will be a great session. So Professor Khaled Mohsin, I like to request you to present your case. And in the second half, Chowdhury Hafizul Hassan and his team, Christoph Sisu and Dr. Omar Farooq will present their cases. So first of all, Professor Khaled Mohsin.
Thank you, Professor Atahar, for your kind and elaborate introduction. Actually, you are too much gracious about choosing adjectives about me. So I think I don't deserve all those accolades, actually. So respected panelists from home and abroad, a learned audience. Actually, this is a rather hastily arranged topic. I think I would have loved to have some more time to prepare myself, but Atahar didn't allow me, and he almost imposed on me to present today. But I am grateful to him for giving me an opportunity. So let me share my screen. Sorry. Can you see my screen, everybody?
Yes, it is seen.
Yeah.
Yes, we
Okay.
can see.
Okay. Actually, the topic of my presentation is the interplay of heart and the device. Actually, heart is a very efficient and tireless organ of the body. Even when we are at sleep, the brain gets some rest, but the heart it started beating in the mother's womb in the end of first trimester, and it goes on and on unabated and uninterrupted until death. But sometimes there is the loss of symphony of beats due to some disease process, and at that time we need to take the help of another very efficient device which is known as the pacemaker. So it's a very intricate interplay between the very efficient organ and a very efficient human-made device. Though it is not perfect, but it is life-saving, and it very judiciously monitors our rhythm of the heart and interferes time to time, and it is sometimes life-threatening. Whenever we see an ECG like this, it is not a pacemaker ECG, but sometimes the pacemaker ECG resembles this type of ECG, which we commonly know as the left bundle branch block. And we need to check this type of ECGs when we must look for a pacemaker artifact which might come before the P wave and before the QRS complex in a very synchronous manner, or sometimes in an asynchronous manner as well. So whenever we see a white complex ECG, we must keep in mind that it might be a pacemaker ECG as well. And this is a common pacemaker ECG where we can see there is an electrical artifact which is coming just in front of a white QRS complex, and the P wave has got no fixed relationship with this QRS complex or spike. Obviously this is a VVI pacemaker. That means a single chamber pacemaker. It was very commonly used previously, but its use has been on a decline nowadays because the dual chamber pacemakers are being favored by the cardiologists because of the better hemodynamics, and the cost of the device is also going down nowadays, and it becomes more affordable to the patients. So everybody nowadays we are preferring to implant a dual chamber pacemaker nowadays. But this type of ECG is not uncommon in our practice. But we have to keep in mind that the bipolar pacemaker spike are sometimes very small, and sometimes we tend to miss the bipolar pacemaker spike when we are reporting an ECG, and sometimes we are reporting the ECG as just a simple left bundle branch block. So as a cardiologist, we need to overcome this sort of omission so that our ECG report is not ridiculed by the other referring physicians. So we have to keep this in mind. This is another white complex ECG. We are very much familiar with this, and here we can see that there are two spikes actually, one in here there are two spikes, one in front of the P wave and another in front of the QRS complex. Sorry, I need to have this is the spike before the P wave, and another this is the P wave the atrial spike and the ventricular spike, and this synchronous behavior or synchronous nature of the complexes are maintained, and this is, we are familiar with this type of pacing. This is the AV sequential pacing, what we can which is commonly described. And here there is another type of pacing. There is a P wave there, and after a fixed interval there is a QRS complex which is preceded by an electrical spike, which is called the AV synchronous pacing. That the P wave is sensed by the pacemaker, but and after a fixed interval, a QRS there is no natural QRS is coming, the spike is given, and followed by there is a ventricular capture. In this way, the pacemaker maintains the AV synchrony, maintains the hemodynamics, and thereby the conservation of the battery energy, because the one spike less is there. So it is a battery conserving measure, but we have to be very sure that the patient has got a good atrial activity, which should be normal and not in case of atrial fibrillation. And the P wave activity should be assessed, and this type of pacemaker programming can be introduced. Here there is some additional pacemaker spikes. It is, some are falling on the P wave, some are falling in the normal location before the P wave, before the QRS complex. This is obviously this is a sensing failure. We come to analyze them in more details in subsequent ECGs. But if we find that this random pacemaker artifacts in different locations of the ECG, we might think that the pacemaker is unable to analyze the intrinsic rhythm of the heart. And obviously, this is a patient on a pacemaker therapy where there is no P wave. The patient is in atrial fibrillation, and in these cases, the atrial pacing is atrial sensing is not beneficial or not in the it is not going to improve the hemodynamics. Only in this group of patient, the VVI mode is the preferred mode of pacing. Then we come to a pacemaker. The pacemaker in a patient implanted quite a long time ago in an elderly person. The patient has no regular follow-up, but the patient has presented with an irregular pulse. So where we can see that the pacemaker, these are obviously, this is the white QRS complex at the paced the rhythm, which is preceded by a spike, but there is a narrow QRS complex after the paced rhythm, and this represents the retrograde activation of the atrium. The ventriculo-atrial conduction is intact. Particularly, these are seen in cases of the sinus node disease, where the VA conduction is intact, and this represents the retrograde activation. And if we can meticulously see that there is an inverted P wave before this naturally occurring QRS complex, and these are the we can this is defined as the echo bit, and this causes some symptomatic the patient has got some bizarre symptoms, and the hemodynamics also is compromised. I would like to have some comment on this type of VA conduction by our experts. Atahar bhai, can you make a comment, or Rafiq sir, please?
Now, first of all, Dr. Professor Khaled Mohsin, whether the sensing and pacing function is okay of this pacemaker. What is your comment?
Yeah. Actually, the pacing, there is actually the pacing function is there is a P wave followed by a QRS complex. The PR interval is definitely very short. We can see that there should be the more gap between the P wave and the I think there is a short PR interval, and that is why the retrograde activation is occurring. So would you please make a comment about it?
So finally, we will take comment from our Rafiq sir, but before that, Dr. Christoph Shoshu, can you make a comment on this ECG, whether the pacemaker function is okay or not? Dr. Christoph Shoshu.
So as Dr. Mohsin said, there is a normal QRS or a pace rhythm after the spike. So the pacemaker, to me, seems to be functioning except for the 1, 2, 3, 4, the fifth beat over here. If you go to the fifth beat, even though there is that QRS, it differs compared to the other space QRSs. So I'm not 100% certain. It's a small QRS, the amplitude is small. On the fifth beat, on the last strip, on the fifth beat.
So Atahar bhai, just to give you an idea that our two participants, Chris Susu and Omar Altalawel, they are both certified in internal medicine. They are just started their cardiology fellowship. So they are not certified cardiologists yet. They are here to learn. So I would not put them on the spot. But I would rather hear from the EP guys.
So Rafiq sir,
can I add something, otherwise?
Okay, Jamil.
After the fast paced and retrograde normal QRS, there is one P wave that is not sensed, followed or it might be artifact. I don't know exactly, but it seems that in every QRS complex before there is a P wave in most of the pace beats, and followed by a narrow complex, and that has also a P wave and in a different morphology. So I do agree with Khaled Mohsin, Dr. Khaled Mohsin, that these are the echo bits that are transmitted retrogradely to the atrium and then again came back to the ventricles.
Dr. Jamil, what do you mean by the echo bit? These are the sense bit, I think. These are the supraventricular. That is the sense bit.
Difficult to say, as because it's the refractory period is so short.
In the bottom strip, you see the narrow QRS complex are preceded by the inverted P waves.
Yes.
So these are the supraventricular ectopics, and these are nicely sensed. And the time is exit.
Why not that P wave is retrograde P wave of the previous space complex?
That's a good. So we'll take final comments from the Rafiq sir. Rafiq sir.
Yeah. This is an interesting ECG. First of all, Khaled Mohsin, thank you. I contradict one thing. Khaled Mohsin says heart is working non-stop. My father used to say that is not true, because in 0.8 second, heart only works 0.3 second. As opposed to that, brain is working even when we are sleeping. So heart actually is one of the laziest organs in the body. If we live 80 years, heart is working only 30 years. Anyway, that's a philosophical. So I think this is what's happening. Let's start with the third complex. The third complex, there is a P wave followed by a pacing spike QRS.
So Rafiq bhai, since you brought up a very Rafiq bhai.
Yes. Go ahead.
Can you hear me? Since you brought up a controversial subject, the diastole of heart is actually an active process and it consumes ATP.
I mean,
So just for the audience, for the record.
And again, what Rafik sir said, during sleep, brain not at all take any rest. It goes on activating every
So go on with your pacemaker.
fraction of seconds.
okay. So, I mean, if you look at the third beat, there is a P wave followed by Q wave. So this is atrial sense ventricular paced beat. And then there is a P wave, which is about 600 milliseconds outside of the QRS complex.
Yes, sir.
Let's go to the third, fourth, fifth beat, atrial sense ventricular paced. And then 600 milliseconds later, there is a P wave followed by a narrow QRS complex. I don't believe this is a retrograde. Why? For two reasons. One, if you look at the retrograde time to be that long is very unusual. It is possible, but unusual. Second, if you look at the P wave followed by the pacing spike, this pacing spike would retrogradely conceal because it is so short PR. So I think what's happening, this is the atrial sense beat, sensed ventricular pace, followed by a spontaneous P wave, which is a different morphology, no question about it. And then there is another interesting part is if you go up on the top, the first beat, the P wave is positive followed by negative. If it is a retrograde, most of the time in V1, you will see a narrow positive complex. So that makes it, so why this rate is low? The rate is close to 50, 45 to 50. One possibility is that this pacemaker is programmed to a backup rate of 45 bits, DDD 45. Or the battery, I don't know what company device this is. If it is Medtronic, it would not behave like that even after many years. Once the battery goes down, it goes to a rate of 65. So that's my explanation. This is atrial sense ventricular pacing and then followed by atrial beat, which is conducted down.
Sir,
Okay,
sir, can I
continue.
have a question?
Yeah.
Sir, the presence of narrow QRS
Yes.
followed by the pacing QRS, paced QRS. So
Yes.
the QRS is too narrow or very narrow. So is it that due to pacing, the retrograde conduction actually improves the conduction in the ventricle, which results in that much narrowing?
No, I think this is just a conducted QRS complex. So it will be narrow.
Yes, sir.
So it's a conducted QRS complex. We also need to know what the programming was set at. So that will be interesting to know. Thank you.
Sir,
I think we should continue.
Sir, for reporting,
Yes.
what will write? That is it is the paced rhythm underlying complete heart block with. So what will write? That is the reporting.
Okay.
That is the.
If I am reporting it, I will write atrial sensed ventricular pace and also atrial beat, which is conducted. This is not heart block because every other beat is conducted. And the bradycardia is due to sinus bradycardia.
Okay, sir.
So, sir, most likely it is sinus node dysfunction.
Yes,
that,
exactly.
That fires intermittently,
Yep.
and that's why this slow rate is there.
Yes, exactly. I agree with Jamal. That's it.
So Rafik bhai, why the last paced complex look different than the others?
Okay, very nice question. Compared to the first,
different lead.
No.
Bottom,
oh, it's a different lead. Yes.
Different lead, sir.
Oh.
There's a lead change marker is there.
Okay. It's not rhythm strip. Okay. All right. Anyway, let's the speaker continue.
It's not a rhythm strip. It is not a rhythm strip.
No.
Next slide, Khaled, Mohsin, please.
Yes, President. This is another patient, an elderly lady on DDD pacing, complaints of shortness of breath and palpitation. Actually, here we can see this is atrial sensing ventricular pacing, but the pacing rate is quite high, around 120 beats per minute, and the patient is unable to tolerate this high rate of and there is a distinct P wave it is seen, and it is followed by a QRS complex. So we frequently encountered this sort of problems, particularly immediately after a pacemaker implantation, when there is a strong atrial activity, and possibly the upper tracking rate is it's set a bit high, and this sort of patients, particularly patients with ischemic heart disease, can have aggravated symptoms of ischemia, and some patients may go to heart failure as well. So any comment from our experts?
Yes, Chowdhury,
sort of
Khaled
patients.
Mohsin, two things to be, that is the two differential to be discussed from this ECG. One is why it is not the pacemaker mediated tachycardia, and secondly why it is not the atrial flutter. These two diagnoses should be excluded.
Maybe atrial tachycardia also, Atahar.
Abdul Wadud Chowdhury, possibly Abdul Wadud Chowdhury.
Atahar, it may be atrial tachycardia also.
Yes, atrial tachycardia also. Abdul Wadud Chowdhury.
Sir, এটা মুশকিল হলো, look at the first lead one. You can see before each QRS complex there is a spike, and before that there is a P wave. So PMT, the P wave should be behind the QRS complex.
Yes.
After, so it's not PMT, pacemaker induced tachycardia. No. 2 number, flutter. If the heart rate were around 150, I would have thought it's flutter. And atrial tachycardia, yeah, that's a possibility. But in that case, the ST segment should show some changes, which I cannot find out.
So what is your diagnosis? That is the sinus tachycardia?
I think it's sinus tachycardia.
Sinus
But the
tachycardia.
rate is
Atahar bhai,
And I think
120.
That's why the heart rate is 120.
Atahar bhai, in this case, the upper tracking rate, can it be manipulated, or the sinus rate can be suppressed by some agents like ivabradine can help the patients?
Yes, that can be. But if it is if the diagnosis is important, if it is a pacemaker mediated tachycardia, that can be controlled with some programming, like increasing the PVARP. So diagnosis is very massive. Unless we change the programming, it is difficult to control the pacemaker mediated tachycardia. So diagnosis is very important. According to Professor Chowdhury, there is the P before the QRS complex in lead 2. So this is against the pacemaker mediated tachycardia, but spike before QRS and the rate is nearly 130. These two are in favor of the pacemaker mediated tachycardia. So if there is no more comment, Ropik sir.
Okay. Well, the rate is 115. It's a cycle length of 520 milliseconds. It's about 115. So two possibilities. One, and all the possibilities are discussed. I doubt very much that this is PMT, because PMT will happen at the programmed upper rate.
Yeah.
And it is very unlikely that we program upper rate at 115, usually 120, 130, 140.
Yes.
Those kind of numbers. Second, as Professor Chowdhury mentioned, there is a P wave before each QRS complex. So one possibility is that this is just sinus tachycardia or an atrial tachycardia being tracked. But please remember other possibility, also atrial flutter that Atahar mentioned, because the rate, if it is 2 to 1, because once the flutter rate will go above the upper rate, it will become 2 to 1. And that will fit into atrial flutter. The simple thing to do is to program this pacemaker to VVI to see what the underlying rhythm is. So if this patient was in my clinic, what I will do is that I'll reprogram the pacemaker temporarily to a rate of 50 to see what the underlying rhythm is. And of course, the treatment will be that if you are finding, treatment will be based on the etiology of the condition. I mean, if it is sinus tachycardia, as Khaled Mohsin said, we can use beta blocker, or we can use ivabradine if need be, or if it is atrial flutter, atrial tachycardia, to be treated appropriately. Thank you.
Professor, can I move to another similar ECG, please?
Please.
Okay.
This is another ECG, almost similar. Patient having a DDD pacing for tachybrady syndrome, complaining of dizziness. This is if we can compare with the previous ECG, the first part of the ECG, there is the P wave. It is not very discernibly visible here, but the pacing spike is there, and the rate is even more than 130, and there is abrupt change of the morphology of the ECG following a ectopic beat. And following the ectopic beat, we can see that very nice AV sequential pacing. So this is a example of pacemaker mediated tachycardia. Can I have your comment, please?
In the first part,
is
spacing spikes are falling on the T wave, right?
Yeah.
I think that's an artifact, and
sir, it's happening regularly.
Yeah, it is, but I think I agree with Khaled Mohsin. You know, if you look at the next one, also it looks like funny spike, but I think that's an artifact, and probably first part is a PMT, followed by termination of PMT, followed by AV sequential phase rhythm.
Sir, without any intervention, whether the PMT can stop suddenly, spontaneously?
Yes, it can. If there is a retrograde block, or what happens, let's say the retrograde conduction comes within the post-ventricular refractory period, then it will not sense it anymore. The third is a very remote possibility, is that, which is very, very unlikely, that there is this narrow QRS conducted this pacing spike, came down. This is very, very unlikely. I mean, PMT can stop because of those two conditions. Retrograde block plus, or retrograde conduction becomes faster with P wave falling within the post-ventricular atrial refractory period.
Right, sir.
Thank you.
Atahar, can you please comment on how to prevent pacemaker-mediated tachycardia by programming, appropriate programming of the pacemaker?
The commonly what we do is
the upper track.
Reprogramming the PVARP, that is increasing the PVARP up to its that is sometimes the maximum limit up to the 450 millisecond, possibly, I think. Changing the mode and increasing the PVARP. These are the two modalities. Any more, sir? Prof, sir?
But the way, most of the time, the way PMT initiates, let's look at the first QRS complex after the PMT. Atrial paced, ventricular paced, right? So if, because there is atrial pacing, there is some antegrade conduction in the AV node, that's why there is no retrograde conduction. However, if there is failure of atrial capture, the next ventricular paced complex will have a retrograde conduction. And that is the most of the time mechanism of initiation of PMT. Or sometimes it's a PVC which has a retrograde conduction. So first thing, we have to make sure that the atrial threshold is good, number one. Number two, you can reprogram the post-ventricular atrial refractory period. What you do, you pace the ventricle in the during programming and find out what is the retrograde conduction time is, which is doable in a dual chamber pacemaker. You can look at the time and please program it beyond that time. The problem is that when you prolong the post-ventricular atrial refractory period, it's getting a little complex for general discussion. You lose the upper rate. So your upper rate then becomes lower. So that's the problem with that. But please remember, most of the time, reason for initiation of PMT is failure of atrial capture. Thank you.
Thank you, sir.
Okay, Atahar, can I move?
Yes.
Another
Yes,
ECG, please.
Yes,
I have a
sir.
logistic question, Rafiq bhai. In US, we have an issue with the pacemaker. We have the pacemaker interrogation or device interrogation. Dr. Khaled Mohsin, Khaled, what is the service you get in Bangladesh? Do you get any interrogation? Sometimes we do interrogation ourselves, particularly when there is an ICD issues. What services you have, like in Bangladesh, for the device interrogation?
Actually, this is not optimum actually, and most of the time, apart from the qualified electrophysiologists like Atahar bhai, Dr. Mohsin Hussain or Dr. Abdul Al Jamil, they used to call the service personnel to their consultation suite, and they direct them and they manipulate the parameters according to the instruction of the electrophysiologist. But in the most of the cases, the pacemaker, the company personnel, they do the programming. They do the
because
programming.
Your first patient did not have any device check for a long time.
Yes.
I just wanted to make sure that
yes. And this is another problem, because in some of the patients, they implant the pacemaker, then they go home and they don't return back for the change of parameters at 6 weeks time or yearly follow-up. And some of them, they are so reluctant, they come with end of life pacemaker, and the pacemaker cannot be even interrogated at that point of time. So this is a real problem regarding the pacemaker follow-up, and you will be very much disappointed to hear that in the most of the hospital in this country, apart from maybe an ICVD or a few Evercare hospital, there is no organized pacemaker follow-up clinic as well. So it is in a very haphazard fashion the pacemaker patients, the ICD patients or the CRT patients are being followed up. And this is one of the reasons that the optimization of the device is most of the patient, it cannot be made possible. I think Atahar bhai or Rafiq sir, they have tried their best.
I'd like to add something. We don't have the programmer in our hospital, so we have to depend on the company people. And whenever, usually what I do, I ask the patient to remain connected with the company people, and I do pacemaker follow-up on every Wednesday at the OPD, and ask my patients to call them when they can give time on that particular day, and according to that they take my appointment and come, and also the company people come, and I interrogate with the assistance of the company people. And
thank you. The next case will show us even more on this. Let's see.
Okay, thank you. Thank you. This is a patient, a 63-year-old male with a dual chamber pacemaker implanted about 8 years back, and the patient presented for follow-up. We can see AV synchronous, AV sequential pacing, but in some cases, particularly some P waves are isolated, and there is a complex which has generated some abnormal P waves. So possibly the ventricular lead function is normal or optimum here, but the atrial lead function is questionable. Can I have the comment of the experts, please?
Most likely, this type of feature comes when the atrial lead floats on the atria. It's not in contact with the atrial wall. In that case, sometimes it is sensing, and there is sequential as well as synchronized pacing. But sometimes it misses the P waves to sense, and there is no complex after. There is a gap followed by especially in the fourth, fifth, sixth beats, there is a sequential pacing. And again, after that, there is synchronized pacing. Probably sometimes the atrial lead touches the atrial wall and sometimes it doesn't. That might be the most likely possibility.
Can I comment?
Yes, sir.
Okay. So if you look at, forget about the first V for the general audience. Second one, there is a P wave followed by a QRS complex, so atrial sense ventricular pacing. Third bit, atrial sense ventricular pacing. Fourth, atrial sense ventricular pacing. Fifth bit, there is a P wave. So there is no pacing spike or QRS. That means this P wave was not sensed.
Yes.
And because of that, it pays the atrium and pays the ventricle. Look at the timing. It is a ventricular driven timing. I think the device is programmed 60 and the atrial pacing spike coming exactly after 1000 milliseconds, which is the rate of 60. And then there is a P wave, which is not sensed. Atrial sensed, paced, ventricular paced. Again, another P wave not sensed. So what happened? I think this is the 8-year-old pacemaker. I don't believe the lead is floating around because it is 8-year-old. So what happened? The sensing can change. Let's say the P wave was 2 millivolt and the pacemaker was programmed at 1 millivolt sensing. And for some reason, fibrosis, the P wave now is 1 millivolt. So if it is 1 millivolt, programmed at 1 millivolt sensing, you will sometimes sense, sometimes not. And the best thing is to interrogate this device, measure the P wave in amplitude, and program the atrial sensing less than what the P wave is. So you will make the atrial sense a little bit more sensitive, and that will probably solve the problem, provided everything else is fine, the lead impedance and everything is fine. I'll not, it's just a question of reprogramming this pacemaker.
Thank you, Khaled Mohsin.
Okay, let's proceed further. This is also a patient with a dual chamber VDD pacing. We can clearly see the P wave is sensed, followed by a ventricular pacing spike. But the expected morphology of the paced ventricular beat is likely to be left bundle block pattern. But in here, we can see that the QRS morphology is a bit different. So what's your comment? Whether the ventricular lead, is it is functioning properly, or it has generated something, a bit which we define as a pseudo fusion bit, which is and does it indicate any pacemaker malfunction?
And was this program lead program to unipolar? The spikes are too large.
No, unipolar.
But the QRS morphology is not
Very narrow. Very
ideal QRS morphology for a paced rhythm is not visible here.
Sir?
If there is nobody commenting, so this is normally functioning pacemaker, atrial sense, ventricular pacing, but it's a pseudo fusion. It's a conducted QRS complex. We are just wasting battery in this pacemaker. This pacemaker should be programmed with a longer AV delay so that it will allow conduction, and if it is beyond certain level, then it will pace. So, and if this pacemaker has a dynamic AV delay on, that should be turned off because it is simple wastage of pacemaker battery. This patient does not need this pacing, but this is just pseudo fusion. It's a good ECG.
Rafiq sir, so can the patient be symptomatic because of this sort of pseudo fusion bit, or it is like unlikely to produce any symptoms?
This has no clinical implication at all.
Okay.
Unless
and neither.
Unless if this is programmed unipolar, you can see muscle twitching in the clavicular region. Because if it is unipolar programming, the electricity passes from the pacemaker can to the device, and sometimes it can cause muscle twitching in the pacemaker area. Otherwise, it should not cause any symptom at all.
Yeah, so we should not misinterpret this ECG as a pacemaker malfunction. It is the main take-home message should be from this ECG that this sort of ECG can be normalized with a little bit of reprogramming of the AV delay, as Rafiq sir has mentioned.
Rafiq bhai, I have a comment, because we see that chronically paced right ventricle has an implication. But I like this thing that we always let the native conduction allow, and we don't need to consume the battery and give forced RV pacing. Here, we are basically seeing forced RV pacing. That may have, some reports about RV dysfunction and shortness of breath. But I liked your comment that we always should allow the native conduction. So PR interval program longer, so it conducts, and we don't need to force pace all the time.
Yeah.
Can I move ahead? This is another 65-year-old man with a dual chamber pacemaker. He had a blunt injury to the chest while he was driving, steering wheel injury. And after the steering wheel injury, this ECG was taken. And can you please make a comment about this? The ECG is showing the right bundle branch block pattern. And what may be the cause of this sort of, we expect a left bundle branch block pattern, and there is two spikes are coming at a perfect timing, but the ventricular capture is not normal.
In all these ECGs, a rhythm strip would have been much helpful.
Yes.
Anybody want to comment on this?
The ventricular spikes fall on the P wave, and atrial spikes, sometimes it seems just before P wave, sometimes much earlier than P wave. So to me, both capture failure in both the leads. I don't know what may be the cause.
Okay. So let me comment. So there is atrial pacing spike and the ventricular pacing spike. But atrial pacing spike, if you look, the problem is the rhythm strip. But if you look at lead 2, there is P wave before, after each atrial pacing. And the AV delay probably is set at 120 milliseconds. And so I think the Jamal's point is that why the QRS pacing spike is on the P wave is because there is delay in the atrium, but it is not capturing in the ventricle. I'm not sure that this has anything to do with the accident. Why? Because we don't know what happened before. If something happens during the accident, you will fracture the lead, which is unlikely. If you fracture the lead, then you will not see any pacing spike in the ventricle. So I think there is, unless there is blunt trauma to the chest, which caused increase in ventricular capture threshold. So it's basically ventricular pacing failure. Whether it's related to the accident or not is debatable. Okay, let's move on then.
Otherwise?
Yes.
What is the follow-up on the patient, Khaled, Mohsin?
Actually, it was found that the ventricular lead has been displaced following the blunt trauma, micro displacement.
Khaled Mohsin, how many ECG do you have? More?
No, I can finish. I can finish.
This should be the last ECG.
Yeah. This is a patient which he had a VVI pacemaker, and he was undergoing elective surgery. And before elective surgery, the pacemaker was reprogrammed. And this was the reprogrammed ECG. So our fellows will like to know that the rationality of the reprogramming of pacemaker before elective surgery and what problems of interpretation it can cause.
But Khaled Mohsin,
Yeah.
actually, what is the ECG diagnosis? 1, 2, 3, 4, 5. 5
Yeah.
beats are captured.
Yeah.
In 6 beats, 7 beats, and there are spikes after the QRS complex. So it is the
Fifth one seems to be a little narrower than the previous 4 bits. This may be fusion bit, and followed by normal QRS complex and spikes after the QRS. On the
1, 2, 3, 4, 5. 4 beats. 4 beats are well captured. 5th beat. 6, 7, 8 beats are sensed.
So let me, Atahar bhai, let me ask you a basic question, because we get this consultative service in the hospital all the time or outpatient, that patient needs evaluation because patient has a pacemaker before surgery. Question is what surgery and what they are going to do. I don't know what surgery, because this has important implications. Because do you need any program if we know what surgery it is? For example, cataract surgery, no need.
Yes.
I'm giving you extremes.
Yes, exactly.
Can I make comment?
Yeah,
yes,
right.
So this pacemaker has been programmed asynchronous and it is continuously pacing. The first narrow QRS, there is a pacing spike just before the QRS. The other one probably in the QRS. The next one is after the QRS.
Yes.
There are 2 reasons that you need to reprogram. Nature of the surgery and nature of the need for pacemaker. This patient, if you look at, this patient has normally conducted QRS complexes. And having a surgery in the leg, there is no need to do anything. Even if this patient is having surgery in the chest, what I will tell them, keep a magnet in the operating room. If you see any long pause, from only reason that you can see a long pause will be use of cautery. So if we use judicious use of cautery, it doesn't create a problem. Only time that we reprogram asynchronous is if there is surgery will be done in the chest and there is possibility of using cautery and the patient is pacemaker dependent. Because in that case, if you encounter a long pause, you will have problem. But we try not to reprogram them into asynchronous mode. We rather tell the anesthesiologist to have a magnet, because if they put a magnet over the device, it can become asynchronous. That's the much better way of doing it. And you look at the last QRS pacing on the T wave. So these are not the things that you want this patient to happen in the operating room.
So Rovik bhai, let me translate this into general cardiology English language, because
Yes.
we do pacemaker for sensing and pacing purposes. If the patient is dependent on the pacemaker and then
Yes.
cautery inhibits the pacemaker, then there will be asystole. So we want to make sure that we force pace the patient with the VOO mode for the general participants, so that we understand in better language that we force pace and then no cautery is an issue. And that because if it is a leg, the cautery is not going to inhibit the pacemaker, so we are safe.
Yeah.
No, what I also add something that is, if possible, to use a bipolar diathermy than an unipolar diathermy, as because unipolar diathermy has a long loop, bipolar diathermy has a short loop, and to avoid any diathermy use within 6 inches of the pacemaker can or the tip of the leads system, and if that's not possible, then forced pacing is applicable.
Excellent point, and this is in the Heart Rhythm Society guidelines, 15 centimeter rule. But I just wanted to make sure that it is very difficult to convince the surgeon with that diathermy business, but it is in the Heart Rhythm Society. But excellent point.
So let me make a comment about the unipolar and bipolar cautery. bipolar cauteries are not very easily available in the hospital. Most of the hospitals, you will have, even in America, you will have difficult time finding it. Forget about Bangladesh. So what you do is look at the placement of your indifferent electrode.
Yes,
If somebody has a pacemaker and you want patient is undergoing abdominal surgery, try to put the indifferent electrode as low as possible so that the circuit is far away. And with the circuit being far away, and then and also cautery use, how is the surgeon going to use the cautery? If the problem is surgeons have to look at the screen that look, there is inhibition, stop the cautery, do intermittent cutting. So those are the kind of advice that you can give to a surgeon, that instead of giving 20 seconds of continuous cautery use, make it into short burst of this. That helps. Thank you.
Atahar bhai, I think.
Yes. Yes. Thank you, Professor Khaled Mohsin, for your excellent presentation and introducing and inviting the excellent discussion about the pacemaker ECG. This was the least discussed part of our ECG session. Nicely presented. Thank you very much, Khaled Mohsin. Our next speaker is Professor Chowdhury Hafizul Hassan. He is waiting. Chowdhury Hafizul Hassan and his team. I think Dr. Christoph Shoshu and Dr. Omar will be with you.
So actually, I'm doing an experiment, and two of our first year fellows volunteered basically, and I talked to Rafiq Bhai because I think as we are starting this institutional presentation, I think it's important that our junior fellows they start joining them and learn how to present and how to interact with the faculty and see how the faculty interact. I think this is very important. And for that reason, I invited Chris Susu from our program and also Omar Talwell. Chris Susu came to us from New Jersey. His recommendation was from Dr. Mark Cohen, who was my mentor. So as you know that it carries a lot when somebody requests and certifies a physician to take into your training program. In the US, this is huge. As Rafiq Bhai once sent me one fellow, he ultimately became an EP fellow and is doing very well. So Chris, he is going to, can you start sharing, Chris, so we don't waste time. Can you please unmute Chris, and then Chris can upload the theme. Actually, I'm going to stand back and then Rafiq Bhai will take over. This is actually an arrhythmia issues, basically ventricular arrhythmias, and we'll talk about the management and how we approach. So Chris.
Sharing, please. Yes, we are seeing it. Chris,
can you hear me?
Yeah, we can hear you.
All right, sorry about that. So I'm going to give you a quick overview. Dr. Hassan can fill in. There's a patient we managed. So our patient, he has some non-specific chest pain, fatigue, short of breath. He was bradycardic. So we were trying to assess for chronotropic incompetence. We stressed him. The stress report did mention some non-sustained VT on his stress. His echo, his EF was, practically 45 to 50%. The patient was giving a tele to go home with, and this is a tele strip. And I would love for the expert to comment on this.
So Chris, looks like you enlarged it.
Yes.
Okay.
So it seems there's
that's a tele, and we enlarge it here so you can see more and a comment from the experts regarding what's going on.
we don't see that very well, but on the top, there's a lot of PVCs. And then in this, we read the lower panel as sustained monomorphic VT. He was actually in a gym cardiac rehab type situation. And we read it as sustained monomorphic VT. He did not pass out, but felt a little fatigued and dizzy, and then sat down and ultimately terminated to normal rhythm without any intervention. So what to do next? Any comment? Wadud, what do you think?
What's the underlying cause?
So let me give you a background. Susu, can you go to the next, Chris? So he has history of this non-sustained VT and also history of recent shortness of breath. And he had a cath because of that. And this was the cath film. And after that, he went for cabbage. So I don't know, Chris, you can play it well, but basically this looks like a like a codominant system, CTO of the circumflex, and then LAD was read as significant, and then right coronary was intermediate lesion and not significant. So next time, Chris, you do it at one by one. Otherwise, it doesn't sync very well. So go to the next slide. So he got cabbage, but during the cabbage, which I found out interesting, that he had a free REMA and then jumped to the OAM, and then all three high-grade OAM and further OAMs were tackled. But the surgeon opted not to do the LAD, which makes me wonder that why that happened, you know. So go to the next slide. So okay, so after that, this happened. That patient came to me, still fatigue and occasional dizziness. So we gave the tele, and the tele showed now sustained VT. So now what to do? LV function actually normal, preserved now, and he doesn't have any symptoms. So he had a recent Lexi scan, like a regadenoson PET scan with ammonia based, and that shows normal perfusion. Normal perfusion, EF normal, and then sustained VT, and then a LAD that the surgeon did not think significant, and then circumflex territory revascularized. RCA is okay. That could have, you can ask that why the CTO of the circ was not tried, why he went for the cabbage, but it is what it is. Not perfect. So what do you do now?
Did you do the other test like the MPI?
Yeah, that's what I'm saying. The myocardial perfusion imaging was done by PET scan, and we use ammonia or rubidium, and we used ammonia in this case, and then PET scan was normal. And then we have this sustained VT, and his referring cardiologist was not happy that the lima was not used. And I looked at the film. I was not convinced either that this was significant. But surgery is already done, and now we thought it is good. He's not that symptomatic. Perfusion scan normal, but because of this occasional palpitation and dizziness, I gave the tele, and I created the problem because we captured this sustained VT. What to do next?
What about his electrolytes and what medicine he was getting?
Okay, so he was on beta blocker, aspirin, And then he was on one of the ARB. We use losartan and then high dose statins.
Mhm.
So yeah.
What was there any scarring in the myocardium documented by myocardial imaging like echocardiography or anything like that? Before
So
the
as I said, you know, if you look at many experts on the echo, they will say the thinning of the myocardial wall is a good way of saying old MI. But his LV function was preserved, and I'm not very good in confirming that there was no thinning, but the LV wall thickness measured was normal. But thinning is a sign for scar, you know, in the echo. Some people do the contrast echo. Some use the myocardial contrast with the myocardial blast echo, but we did not do myocardial echo. And one of the best way to know scar is gadolinium enhancement. He did not have gadolinium enhancement.
So what is the hemodynamic? What is the hemodynamic?
The blood pressure good, heart rate good normally. So any thought? So Rovik Bhai just texted me, he left, he had to leave. Any, so general cardiology issues, but do we surrender to EP or we the plumbers need to look at things again?
Now, if there is no,
So,
sorry.
So this is what we did in this case, that we called back the patient and then we did the cath again. So Chris, do you have the films?
I don't have the film on the redo. No,
Okay,
I don't have the film on.
So the graft, including the RIMA, free RIMA, all good and patent. So I actually interrogated the LID because I was not sure that the intermediate lesion, whether that is playing a role, although this is sustained monomorphic. So IFR was done, not FFR. IFR was 0.96, 0.97. And then that, so we did not intervene. The surgeon was really happy because surgeon was thinking that, you know, this we may have missed the LID, and that's a big issue. So now what?
Can we increase the beta blocker?
So we increase the beta blocker, and then question is sustained VT, increased beta blocker, and then we sent the patient for EP study because we don't know yet whether this is a scar-related VT or there is a problem sometimes we see is the epicardial VT or not. But I'll give you the feedback once we do the EP and come back. Chris, go to the next. We'll go for a rapid fire of common problems. So go ahead.
So this is the next question is a 68-year-old male with multiple medical problems, except for he didn't have any prior cardiac history. The patient is on dialysis. He after dialysis on that day, he went home, and according to the family, he fell and became unresponsive, and EMS were called immediately, and they arrived at the scene. And this was his initial strips here. And this was doing the resuscitation. So, any comment from the experts?
Do we have the blood gas or electrolyte?
His blood gas, the initial blood gas was unremarkable, 7.34. PCO2 was in the 40s. And his oxygen saturation was good as well when he arrived in the emergency department.
And he was intubated in the field?
He was intubated in the field, yes.
Do you have a 12 lead EKG?
That was after resuscitation. So
okay,
this was the initial EKG. He received shock. His ACLS were prolonged, but Ross opting and he was brought to the hospital. This is an ECG when he arrived in the hospital.
I see only QT prolongation.
Okay, go to the next EKG. Okay, good.
So when he arrived, we also did a echocardiogram. So we have the parasternal
Hold
long
on.
axis
Any
there.
EKG comment? Go back to the EKG.
QT prolongation.
Go back to the EKG, Chris.
The strip?
Yeah. No, the 12 lead EKG. Previous slide.
Hey, this one. Yeah.
Okay, good.
Look at this. All the QTs are prolonged.
But I tell you what is our problem, right? That post resuscitation, the emergency room always calls us that post VFib patient should go to the cath lab, cardiology take over, and they are on our nerves. So because VFib, are we missing something? Is it a left main multivessel disease that we are sitting on? A lot of pressure on us. So as cardiologists, what do we do next?
Hafiz bhai,
and as Professor Chowdhury says, yeah.
Electrolytes.
Hafiz,
Electrolytes.
Including magnesium.
Echocardiogram. Yeah, the last echocardiogram that shows there is a apico anterior and there is a scar possibly in the vicinity of the apical region. Was it present before?
We have no previous echo. And the guy does not, and the guy actually has no name because he's,
yeah, we don't know the name yet.
We don't know the name because we
homeless.
We call it some stat name.
Apical fourth chamber view. It looks like there is some apical scarring at the distal. Yeah.
So this is a management issue, right? So how you go from here? Next.
I mean, what do we? So the patient currently is still intubated, very poor mental status.
So the problem
is in the medic
information whether the patient was having chest pain or is it due to electrolyte abnormality. That's the two-pronged thing you have to think about. ESRD patient, home dialysis. So that's the problem.
So his electrolytes were normal, potassium of 4.5, magnesium of 1.9. His phosphorus was okay. His hemoglobin was fine as well. So electrolytes were relatively unremarkable.
Yeah.
We don't know the story prior to him becoming unresponsive because we haven't been able to talk to him. But the family said once he came back, he just failed and then became unresponsive. That's all we have as for our history.
So the important thing is that we need to evaluate these patients before rushing for any procedures. The assessment is he mentally, how we assess the neuro status. The second thing is that the hemodynamics and then the blood gas pH 6.9 or less, very poor prognosis. You need to think about before you do any heavy duty interventional therapies or supportive care. And the other important thing is that if we have this issue of ST elevation, then we are more challenged. If there is no ST elevation, you are thinking that this is a prolonged resuscitation and no obvious reason to go to the cath lab, then we try to buy time and then think about the neuro recovery. In this case, this was a collective decision not to go for hypothermia protocol because of the overall poor prognosis, and that we did in conjunction with the ICU team. So I just wanted to share the challenges that we face, with this kind of problem. And then we found out, yeah.
So actually, what medication he used? Actually, magnesium.
We gave magnesium, yeah. But if the patient, we get in the ER got this bolus amio, but we did not continue patient luckily was not on heavy duty pressor agents, just levofed, then off levofed, and then we are buying time to see whether there is any neuro recovery or not, and then we'll decide about what to do next. It turns out that his tox screen was also positive. Go next. Next.
Cocaine and other things.
Actually, this patient does not have any criteria to activate the cath lab.
Well,
am I correct?
Correct. So this is the problem. We call it that the emergency room can call many reasons to activate the cath lab, but we need to, and then when we go there, we need to decide about the overall. So we need to pay our attention to overall comorbidities, neurostatus, electrolyte imbalance, if any, and then decide about it. And few things important to pay attention to. And unless we get our act together, we may go into a mess, even bigger problem, and also unnecessary utilization of the resources, because some of the patients may be really already in bad prognosis. So we need to use the judicious use of resources. Talking about the STEMI activation, let's look at the next patient. Let's see, go.
So the next patient is a 52-year-old female who collapsed at home. Her medical history, she had depression, anxiety, chronic pain, insomnia. These are her, there's a list of her medications. So this was her initial raving in the field. So we didn't get, EMS didn't scan the whole thing in, but her raving looked like this exact raving. So this is her initial raving when EMS arrived.
She got shocked outside.
Yeah.
Yes, she got shocked multiple times. Yeah.
Next EKG.
So this was her ECG. Patient got shocked, brought to the ED, initially intubated, and then subsequently patient was successfully extubated, and this is her next EKG.
But I think this is a quetiapine and other medication-induced long QT syndrome.
Yeah.
And she had PROSA.
Yep.
Another drug is duloxetine, also causes
Long QT.
Long QT, yeah.
I'm not sure about that.
Most of the psychotropic drugs
Yeah.
cause QT interval.
What about
Yeah. So we thought that this is long QT, then patient got extubated herself, and then mentation was good. What do you do next?
What about the electrolytes? And is there any blood estimation of the suspected drugs? Any overdose or anything?
Have you done the drug level of the medication she was getting? Serum level of drugs.
We don't have the ability to test those drugs level.
Therapeutic monitoring.
Whether there was, as she was depressed, whether she attempted to take all medication at a time to commit suicide. That might be one possibility, to take antidepressant a lot. What happens with the depressed patients?
But Hafiz bhai, I'm always in case of arrhythmia. I'm interested about the electrolytes.
Hafiz bhai got stuck.
Chris, can you give us?
Yeah. So I can hear you. So on this, her electrolyte was unremarkable. Potassium, phosphorus, magnesium, everything was within the normal limits. We did not check the level of her drugs that she's on. We don't have the ability that's a send out lab, so we didn't check the levels in her blood. Her urine toxic screen was negative as well for any illicit drug use. And she, when she self-extubated, she said she wasn't trying to commit suicide. She always took her drug as prescribed. That's what she said.
So that's drug induced. Hafiz bhai probably out of net.
So how?
Hafiz bhai, have you got back to us?
No, he didn't.
Dr.
Yeah, he's coming.
So Christoph, how did you manage actually?
So after, she came in with, tossage. She was shocked. Obviously, we took her to the cath lab to check her coronary. We think it was drug-induced, but we can't 100% say it's drug-induced without looking at her coronary. She has some risk factors. But her coronaries were, as you can see, the angiogram, they were unremarkable. No obstructive coronary artery disease was seen on her coronary angiogram.
Beautiful coronaries.
But Christo,
So then the question is, what do we do with such patient?
Have a talk with his psychiatrist and talk about the choice.
So we are thinking that this is a long QT related torsade. So we did not give any ICD, and this will be a negotiated thing with the psychiatrist to modify the medications and avoid a long QT producing drug. For the participants, I would say we may not know long QT, which drugs cause it. If you Google it, actually there is a website, long QT website. You can get the list of the drugs, what does cause. The drugs concentration is important to see, but it may not necessarily correlate with the presence of long QT and the drug concentration. So it may not be helpful, particularly if you know that the patient is already taking drug. Sometimes drug assay helps if you are not sure that the patient was taking the drug. But if the patient drug is already in patient's list, then it is good enough. And one of the way to do that, and I'm sure that one day in Bangladesh, and it's already happening in Bangladesh, that pharmacy now has list of medication that the patients take. Meaning that if we call CVS pharmacy, then the pharmacy will know what the patient was taking, because the patient was taking the medication from that pharmacy and it is in the patient's file. So you can see that. And I'm sure that we can develop that kind of pharmacy list in Bangladesh as well, that what the patients take, there is a list, and it is very convenient way to find out drug interaction and advice from the pharmacy to the patient. I have a pharmacological background, so I'm very emotional about that kind of thing, drug interaction and all that. So with that, I think we are running out of time.
Yeah.
Omar actually prepped the case. So if you can kindly give us 2 minutes, so Omar can show the last case, because I told these guys to participate, and I really appreciate all of you to have the patience to allow the fellows to present the case.
We really enjoyed it. We really enjoyed it.
Thank you.
So Omar, are you okay to?
Yes, yes, sir. Yeah, I'm ready. Okay, let me share the screen.
Just that to let Omar and Chris know, in Bangladesh, this is already 11 o'clock in the night. So you realize that these guys are all.
And not yet. There's 20 minutes to 11.
Yeah.
Okay. So I'll be quick. Can you guys see my screen?
yes, we can see.
Okay. Thank you very much for the opportunity. I will start the case. She's a 68 years old female patient with past medical history of liver cirrhosis. She presented to the ER status post cardiac arrest. EMS picked her up from her resident. They found that she was vomiting blood, lost her pulses, and she received CPR and intubated en route. On arrival to the ER, she was hypotensive and tachycardic. These are the initial vitals. And as we said, we don't have much information at that point, and cardiology were consulted for this EKG.
So this is very important that we ask what was the rhythm, because I always ask this question, that is the first rhythm, noticeable rhythm, is VFib or pulseless electrical activity or asystole, because VFib is something that we are involved heavily. If it is a PEA arrest, patient with post-MI or primary cardiac coming with PEA, the differential goes other way, like pericardial effusion, tamponade, or severe hypoxia PE on that route rather than cardiac. We did not have any exact rhythm, and sometimes late in the game, after AP, VFib appears, that does not count heavily, as without any intervention, first rhythm is VFib. So we don't know in this case what happened, but this is the EKG. So any comment? You know, there is a very funny way of looking at EKG. When we look at this EKG, we look at tachycardia and significant ST changes, lead AVR, ST elevation, and there is deep ST depression. But the EP guys will say they will spend more time, and Rafiq Bhai is not here, I'm pulling their legs. They will spend half an hour to find out this is a AFib or what. But
first, the rhythm is irregularly irregular.
Yeah.
There is no discernible P wave.
Yeah.
And there is gross ST depression in lead V3, as well as V4, V5, V6. And that may be tachy induced also. And if that's
so
what I say.
Because of this AVR, ST elevation, deep ST depression, they actually, this case, they actually activated the cath lab for ST elevation MI. And now we'll have to deal with this. So our problem is that when they call us, it is the emergency room physician and only cardiology, no ICU. And problem is that the ER wants this patient out of the emergency room, because then it is not their headache. It is our headache.
Deshouldering.
And once you take it, you cannot get this patient back to ER. So your cath lab will be stuck, and if it is cardiac, it is yours. If it is not cardiac, at that point, it is very difficult to give this present to someone else. So this is a big problem. So we need to decide. That's why we train ourselves that we buy time in the ER before we buy in this asset, you know. I take it this
Actually,
way.
half is way.
Yeah.
This kind of ECG often we get with the CKD patient having hemodialysis. Often they present to the ER with shortness of breath with atrial fibrillation, and they come to the CCU. And after that, the nephrologist do not want to take it over. They keep it there, their advised dialysis, and I have to follow up the patient in CCU. They don't want to take over. They don't want to shift the patient to the ICU even. They say, no, he has atrial fibrillation, so it's a cardiac patient.
Yes, you are absolutely right. So it's a big problem. So I think we need to work in together as a team.
Yeah.
But my view is, if it is predominantly cardiac, I take it. If it is predominantly ICU, then you take it. But question is, what do we do in this kind of patient? So I usually buy time in the ER, get more data, because patient is already, you know, intubated, and then they're thinking about what to do. So it turns out to be, Omar, you have the further data?
Yeah, so we tried to buy time, so we repeated the EKG. We thought this could be because of CPR and they given epi. So the repeated EKG was also similar.
Yes.
So the stat lab, the initial stat labs we had, that was the hemoglobin 5.3. The patient was severely acidotic as well. There was no major electrolyte abnormality, some hypokalemia. However, acidosis and low hemoglobin was the two significant findings. The patient with like intubation with suction found out to have a lot of coffee ground emesis. They started massive transfusion protocol, and luckily at this point, after starting, she initially used pressors, but with the blood pressure recovered, and GI were on board for this patient for urgent.
So there is another problem now, right? It was actually good for the patient that there was a revealed bleeding. If it is a concealed bleeding, it's a bigger problem, because the GI is always the problem, and then you do GUAC test, and then you suspect, you call the GI. When you call the GI, you have another problem. The problem is GI says this is cardiac. We need clearance. And this concept in the hospital that cardiology is a clearing forwarding agent, I don't buy that. We say we actually minimize the risk or we optimize the patient. We said this is, extreme example is if somebody is having a STEMI and a femoral artery laceration, who takes care of the patient first? I give that example always because it is a coordinated work. So the GI will say, I'm not going to go in because the patient is cardiac MI. And actually it is not the GI, it's the anesthesia who gives this sedation to the patient for the scope. They got worried. What do you do at that point? How to assure them that, hey, we are holding your hands, you go first, fix the bleeding source first.
Yeah.
I'm sure you have the same problem.
Yes. And anesthetist push towards again towards the cardiologist for to give anesthesia.
So yeah, I am absolutely very friendly with them. And I said, look, I'm doing the next thing, which is an echocardiogram. And always echo is helpful. And look at this echo, what we found. And we told them that you go first. But we did the echo bedside. Omar, you have the echo film?
Yes, sir. This is the echo. This is the peristernal long axis. Any comment from the experts?
How old?
It seems there is no regional wall motion abnormality and contracts very well, almost obliterating the lumen. So it's super dynamic.
Jamil bhai, excellent observation. Actually, this was hyperdynamic with LV outflow tract functional obstruction.
Yeah.
And the patient has previous history of hypertension. And this is not familial hypertrophic cardiomyopathy. This is hypertensive hypertrophic cardiomyopathy. And the alveolar functional obstruction. In the case of hypotension, it helps a lot. It gives fluid resuscitation, fluid, blood transfusion. And if we need to give any vasopressor, it is primarily not levofed, it is vasopressin or phenylphrin, basically alpha blocker, helpful. But the patient got the GI endoscopy. Sorry, Omar, I'm rushing because it is already getting late. So they got the GI endoscopy and what they found?
They found there was a deep gastric ulcer. They had to cauterize initially and clip. And yeah, that was the finding.
And of course, the troponin will come positive. Still the team will be on your nerves. Will you do angiogram or not? I told them chill. LV function normal, little troponin, anemia, type 2 MI. You need to stand, back a little bit, and then we can do a evaluation later on. There is no rush. So patient survived and did well.
Actually, any hollow viscous trauma causes raised trophi from the smooth muscle. So any assault to the gut, stomach might raise that troponin to the mild to modest level, and that does not mean that the patient has NSTM.
Okay, so I will show a couple of cases next time with this concept of troponin.
Yes.
And type 1 versus type 2 MI and interaction. But that's what we have for today, unless you have any questions. Omar, you have anything to say?
No, I have the just the gradient through the LVOT and the M mode just to look at the LVOT.
Okay. Thank you.
Thank you.
Thank you very much for nice cases.
That's concentric remodeling.
Yes.
Thank you, everyone.
These are very practical cases that we can find anywhere in the world.
Yes, exactly.
These are very nice cases. And Omar and Chris, very much thanks to you.
Thank you. Thank you for having us. I learned a lot today. Christoph, no ER.
Okay, Christoph. Okay, thank you.
Yes.
There's a little bit of French influence, Christoph.
It is French, yes.
I'm right.
All right.
We should remember something. It's the hemoglobin that is the key to carrying oxygen. Because if you are reducing the partial pressure of oxygen by half in the breathing air, still your blood will contain enough oxygen to sustain you. But if you reduce your hemoglobin by half, your oxygen level will be around 1/3 to 1/4 of what it has been before. So any ST elevation in a very anemic patient, we should try to resuscitate, particularly if the patient do not have a discernible history that suggests that this is an ischemic origin. Because that's secondary ischemia. We have to correct the anemia.
You know, when we talk about the Krebs cycle, the oxygen hemoglobin dissociation curve, it makes us panic, it takes us to the medical school again. But but one important thing that in the oxygen dissociation curve, hemoglobin oxygen dissociation curve, but think about that along with hypotension, significant. That screws up the whole thing about hypoxia related myocardial injury.
Yes.
You know, because with the hemoglobin oxygen dissociation curve, as we read in the medical school, it is always in the presence of normal hemodynamics. Nobody talks about oxygen hemoglobin dissociation curve in the presence of hypotension. Remember, this patient's blood pressure was 65. So it's kind of interesting. We need to have some model that what happens with this kind of thing when there is a change in hemodynamics. Kind of fascinating.
Again, Hafiz bhai, this hypotension also lead to some damage to the skeletal muscles also, from where this troponin is also released.
Yeah, but the high sensitive troponin, the skeletal origin is almost not heard of. But cardiac troponin is okay. You know, we know that it can be injury, it can be hypoxia related, it can be type 2, it can be non-type 2, and is still injury pattern. But troponin means nothing at this point.
Yes, yes.
So,
Atahar, would you wrap up?
yes, actually, excellent cases, beautiful presentation, and nice discussion. And congratulations to our first speaker, Dr. Khaled Mohsin, and finally, Dr. Chowdhury Hafiz Hassan and his team. Particularly big congratulations to Dr. Omar and Christoph Shoshu. Dr. Omar and Shoshu, actually, we enjoyed your presentation and we want to have you in the every session in the Saturday, this time, every time in Bangladesh. Big congratulations.
Thank you very
And
much.
finally,
Thank you for having us. We'll try to be there.
Okay, Christoph Shoshu will come. We enjoyed your lecture. And this is the time. Actually, in next Saturday, our presentation will be from Dr. Poppy Bala. Dr. Poppy Bala, and the second time, in the second part of the session, Dr. Rafiq Ahmed sir. So, Dr. Ashif Jaman Tushar, we will conclude the session just after a few talks from the Dr. Wadud Chowdhury. Chowdhury, few comments and then Ashif Jaman Tushar.
No comments. Actually, I enjoyed it. I have been late today. I was in a traffic jam. I have missed only a few, around 10 minutes of Khaled Bhai's lecture. But today he focused on pacemaker related problems. He showed some practical problems. Khaled Bhai, many thanks to you, because you have shown some practical problems that we face and how to deal with those cases. That will be very much helpful for our fellows and specialists, both groups. The second, Hafiz Bhai, as usual, with humor and wit and beautiful case selection, his team has shown us beautiful cases that has much learning points, particularly how to deal with a complex situation where nothing is in black and white, everything is in gray. And you have to swim through the black water and survive and have a smile. So these lectures, these presentations, these cases always enlighten us and hopefully will be useful in our daily practice, clinical practice. Thank you, everybody. And Beximco, your team, Ribhu, thank you.
Thank you, sir. Thank you, dear physicians, for attending this. And we wish your continuous presence will enlighten us, will give the
give us more chance to help the students and the fellows to know about ECG in clinical scenarios and how to deal with it. And today, the two sessions basically deals with clinical scenarios and what physicians need to do at that moment. Thank you, Professor Khaled Mohsin, sir. Thank you, Professor Chowdhury Hafiz Hassan, sir, and Christoph Sosu, and Dr. Omar. Thank you, Beximco Pharmaceuticals, for their continuous support. And good evening to all the participants and all the faculties. Thank you and good night.
Okay, good night. Assalamu alaikum.
Thank you so much, everyone. Assalamu alaikum.